Morning, Mr. Mendel. Would you please raise your right hand? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
I do.
Thank you. Please be seated.
Your Honor, this is just to set the stage. This is another impact witness. It's also a witness who will address some small issue of the abatement. We're actually putting this witness on a little out of time, but this is the only day he could do it.
Okay. Very good. And Mr. Mendel, just make sure you put that microphone right up against your mouth so we can hear you.
Well,
Thank you.
May I proceed?
Yes, you may.
Thank you, Your Honor. Would you tell Judge Bachman your full name, please, sir?
Gary Michael Mendel,
Mr. Mendel, how old a man are you?
62,
And where do you currently reside?
Westport, Connecticut.
And how are you currently employed?
I am the chairman and CEO of an organization called Shatterproof.
Okay. And would you tell Judge Baldwin what Shatterproof is?
Sure. It's a national nonprofit to reverse the course of the addiction epidemic.
Okay. And when was Shatterproof created?
It was formed in the first quarter of 2012
Okay.
and launched publicly in September 2013.
Okay. And how many years did you spend researching and preparing for the creation of Shatterproof?
All of 2012 and the first 9 months of 2013.
Okay. Was there a time before Shatterproof when you lived a totally different kind of life?
Sure.
And if so, what I'd like you to do is tell the court about your educational background and your work background and just basically about your life before Shatterproof. Okay?
Sure. Graduated college in 1979 with a degree in hotel administration from Cornell University. Worked in the restaurant industry for a few years, and then formed and launched a hotel investment company in my when I was 26 or 27 years old. And that company grew to about, not to about, exactly 22 hotels that we owned and operated. And then in January 1997, sold that to Starwood Hotels and Resorts. I became the president and CEO of the president of Starwood Lodging Trust, which was the real estate side of Starwood Hotels and Resorts, and I was on their board of trustees. I then retired in last day of March 1998. So I was there for about a year and a quarter, and spent 4 years pretty much retired, spending a lot of time with my children. And then in January 2002, reformed my hotel company all over again. And when we reformed it, we created discretionary funds, which are private equity funds where investors invest money with us on a discretionary basis. So it's our ability to invest that capital. We first raised a $275 million fund with 8 college endowments, some of the leading universities in the United States. Then 2 years later, we raised a $425 million fund. And then 2 years later, we raised a $525 million fund. And we acquired about $2 billion worth of real estate over the ensuing years. And we were one of the leading owners and operators of hotels in the country, of first-class, full-service hotels. And we were getting ready to raise our 4th fund in the fall of 2011 when things changed for me, and
Can I stop you right there for a minute?
Sure.
So I heard of Starwood. So you actually built Starwood up into a very successful business, and then you retired.
Correct, although I don't think it's fair to say that I built Starwood. I was one of many leaders there, and I was only there a year and a quarter. But while I was there, we bought the Westin hotel chain, and we bought the Sheraton hotel chain. Took it from approximately 100 hotels to 700 hotels, and owning the brands.
Okay. Would it be a fair statement, and I've known you for a number of years, you're a humble guy, but I don't want you to hold back. I want you to tell Judge Baldwin about your successes. Was it a very successful business that you built this into before you retired?
I mean, sure. Today, the company, which still goes, I still own the business, but I don't work there anymore. We oversee hotel revenues of about $2 billion. We have about 85 hotels, first-class, full-service hotels in our portfolio all throughout the country. We're the largest franchisee of Marriott, of full-service hotels in the world. I'm equally proud of the fact that after I left the business, the leaders in the business didn't skip a beat, that the company was run so well that it continued to grow without my involvement.
Okay. So why did you come out of retirement that first time?
4 years spending time with the kids, getting an itch to get back into the business, seeing opportunities after the tragic events of 9/11. Real estate values plummeted. It was an opportunity to get back into the acquisition mode and acquire hotels.
Okay. So then, your second go-around, after you came out of retirement, your second hotel business, did you say it's called HEI?
Same name, HEI Hotels and Resorts. We hadn't sold the rights to the name. I just had a non-compete for a time period. And
did you build that business into an equally successful?
Yeah, that's the business. The second go-around is where we raised discretionary funds from endowments. Our first fund was 2004, as I mentioned, $275 million. And then 2 years later, 2006. And then 2 years later, 2008, is when we raised all that capital, all from college endowments. First fund was 8 college university endowments. Again, these are the leading universities in the United States. Second fund was 9 university endowments. And the second fund was 14 university endowments were our investors. 10-year discretionary capital. As long as we bought hotels in the United States, it was all within our rights to do so.
So you were really wildly successful in your business endeavors?
Sure, I hesitate to use the word wildly, but certainly by most measurements, we were extremely successful in how we operated and what we succeeded at doing.
Up to that point, did you have a good life and think things were going pretty well?
Yes, I did. Although I had a wonderful life, but my older son Brian was struggling with addiction.
All right, would you tell Judge Baldwin, well, before we do that, let me ask you this. You're an incredibly successful businessman, well-educated. Did you know anything about addiction?
I did not.
Did you know what an addict looked like?
I did not.
Did you think in your wildest dreams that your firstborn son, Brian, could become addicted to anything, really?
Mayor, I'm sorry, Mr. McDowell, I'm going to interrupt. But
That's okay.
For purposes of the record, this was subject to a motion of money on impact purposes, and I just reassert that objection for purposes of the record.
Thank you, Mr. Ottaway. We'll note the objection and
Sorry to interrupt.
overrule. Go ahead.
Did you ever in your wildest dreams think that your son, Brian, could become addicted?
It never went through my mind. I knew very little about addiction. There was no one in my family addicted. At least I didn't know at the time. Turns out there was. Didn't even cross my mind. When I saw a beer can in his bathroom one time in the garbage, didn't think anything of it. I thought it was a normal high school kid with a beer can. When he was caught smoking pot in high school, I thought it was normal rites of passage of a high school student. never dawned on me at all that there would be any issue besides normal growing up.
Before Brian became addicted, did you think he was just a normal kid and a good kid?
Absolutely.
And what did he end up becoming addicted to? Just tell the court what happened.
Sure. It started with marijuana, and we became aware of it really in his junior year of high school, that it became a problem, that it was more than a typical problem. And then we, at the advice of a psychologist, we sent him to I'm spacing out right now, I'm sorry, a wilderness program out in Utah. And from there, it led to 8 different treatment programs over the next 8 years, where the problem escalated. It got worse versus getting better. His use went from marijuana to Xanax, to Oxycontin, Vicodin, and ultimately heroin.
Over what period of time?
Over 8 years, from age 17 to age 20. Well, let's rephrase that. Let's say 7 years, because age 17 to 24. Age 17 to 24. Let's say 17 to 25, 8 years.
And can you tell the court about your last visit with Brian? Actually, before we do that, Your Honor, we actually have a picture of the last picture of him and Brian. Would you mind if we show that picture?
I have no objection.
No problem. Go
Can
ahead.
you do that, Mike? It's that last picture. Would you tell the court, by the way, just for the record, how many times have you gone around this country speaking about what happened to Brian, and do you use this photograph when you speak about this?
I've spoken hundreds of times all over the country.
Are you one of the leading voices in the country on addiction and specifically on the opioid crisis?
I am now, yes.
And tell the court about Brian's last visit home. You look pretty happy in that picture.
Sure. It was 4 months before he died. He came home in June. He was living in California. He came home for a visit and had a great day that day. We played golf in the morning, had a family barbecue in the afternoon. And then when everyone went home, it was just the 2 of us on the back porch talking. We're talking about his favorite topic, the Giants, Eli Manning. And then when the conversation turned to his recovery, he looked at me and he said, "Dad, I wish that someday people would realize I'm not a bad person. I'm a good person with a bad disease. And I promise you, I am trying my absolute hardest." At that point, he hadn't used a substance in almost a year. They flew back to California.
So, when did Brian lose his battle with addiction, Gary?
Well, in September, I flew out to see him for his 1-year anniversary of being substance-free. Spent a weekend together. And then 5 weeks later, I received a phone call in the middle of the night. And I picked up my cell phone. I couldn't believe who was calling at 1 o'clock in the morning. And when I picked it up, I was told that Brian had just died. So that was October 20th, 2011.
And did Brian have a particularly difficult time struggling with an addiction to opioids?
Absolutely. A little more description of that phone call that I received. He didn't die of an overdose. Even more tragic, and I hate to say, and I don't know if I should rephrase that because it's just as tragic losing a child to an overdose. So why don't I say equally tragic, but a more important part of his story, our story, is he took his own life. The history on his computer shows he woke up that morning, researched suicide notes, wrote a note of his own, as loving as you can possibly write a suicide note, a paragraph to each of us, and then lit a candle and took his own life, alone. Prior to that, he had gone to 8 different treatment programs. Each one was different, except for one common element. Not one of them treated my son with treatment that was based on science, on proven research, just like we do for any other disease. At one treatment program, I asked, "Are you treating him for his anxiety?" They said, "No, we don't do that. He's just got to stop using drugs, go to AA meetings, and develop more discipline." And another treatment program, I found out later that they had forced him to scrub toilets with a toothbrush. And when I found out about it, I asked why, and they said, "We need to build his character." Another treatment program, they did the right thing. They prescribed one of the 3 FDA-approved medications. He was doing the best he had ever done throughout that 8 years. His old self was back, smiling, enthusiastic, hope. But then they recommended an outpatient program that they said also agreed with the medication. But when he got there, the very first day he met with a psychiatrist, who was only there, by the way, for an hour a week to meet with everybody, in and out. And he said, "No, we don't believe in that medication. I need you to get off right away." And they started titrating him down to below a dose that had any effect at all. I can go on and on. I mean, I don't know where to end.
Well, let me ask you this, because I've heard you speak before. I want to talk about the stigma of opioid addiction. Can we do that?
Sure.
And tell Judge Bachman why eliminating the stigma associated with opioid addiction and any form of addiction, tell Judge Bachman why that is so important in terms of eliminating this epidemic.
We can, unless we change the way that we think about this disease, the way that we talk about it, the stigma we attach to it, treatment, healthcare systems, laws, policies will only be so effective. Stigma changes everything. And let me talk specifically about some segments. But first I'll give you some data. In a recent survey, which was a valid and scientifically reliable survey, 44% of Americans say those addicted to prescription drugs have weak willpower and poor discipline. But over 80%, almost double, said even though only 44% think it's weak willpower or poor discipline, a little over 80% reported, "I'm uncomfortable associating with someone addicted to prescription pills as either a friend, a coworker, or a neighbor." More than 8 out of 10. So how does that affect those addicted and all our systems within our society? How does it make someone feel who's addicted, knowing that more than 8 out of 10 out there, I'm sure they're not thinking of the numbers, but at most touch points in society, say, I don't want you as my neighbor. I don't want you dating my daughter. I'm not sure I can promote you in our business. How does that make someone feel? How does someone feel within our employment system? We have these walks around the country. I met with someone who's a senior leader at one of the largest investment banks in the country. And I asked him, would you sponsor a team at our Boston 5K? He says, Gary, I obviously believe in your cause. He was in recovery himself. That's why I was connected to him. He says, but I can't be associated with your walk. If I sponsor this, people will figure out that I'm in recovery, and I may not get promoted. He says, last year I relapsed. I told people I was on vacation. I wouldn't tell them I was in recovery. I was going to a treatment program. There's no way I run this through my insurance. They may figure it out. That's just one example. Our entire employment system in this country. You could talk about how you have diabetes or heart disease or cancer or a family member, but no way you're talking about, I'm struggling with addiction, or I have a son or daughter who's struggling with addiction. And that's in our employment sector. We just did work to study why primary care doctors are not treating those who are addicted to opioids. What did we learn through surveying? What did we learn through one-on-one interviews and roundtables? I don't want them in my waiting room. If I treat one person who's addicted to opioids and he gets out, there'll be a floodgate in here. I can't have that. It'll ruin my practice. Other responses. Why should I treat them? They just need to try hard enough. They're not trying hard enough. It's their fault. Another response. Let them die off. They're a weakness in society. That's what many in our healthcare system believe. So how does that affect those who are addicted? No capacity, not enough capacity in our treatment system. You have heart disease. One of us wakes up tonight with chest pains, and we go to our doctor the next morning, our primary care doctor. He will know enough that he's learned in medical school, based on a set of questions, to be able to say, you know what, based on what you just told me, you should go to the emergency room right away. I'm calling an ambulance. Or based on what you just told me, here's 3 specialists. Go see one. Or based on what you told me, I think you're going to be okay. Go to CVS and pick up a prescription. But they haven't been taught this. Most doctors aren't taught this in medical school. Why? Because it's viewed as not a disease. It's not regularly taught in our medical schools or our nursing schools or our professional training schools. Why? Stigma. It's not a disease.
Gary, let me ask you, I heard you talk before, did you have an acquaintance with Brian's while Brian was still alive?
Did I have what, I'm sorry?
An acquaintance who had cancer.
Yes.
Would you tell the court the comparison to how that young man with cancer was treated relative to Brian?
At the same time, Brian was going through this in high school. Another young man, Brian's age, was also in high school in our town. When he was diagnosed with cancer, his family told all their friends. Well, first of all, before they told their friends, the first thing they did was research and find treatment for their son for his cancer. And as anyone in this room would expect, they found treatment that was based on science, on proven research, just like any disease. Doctors who were taught based on science. We looked for care for our son, and as I just mentioned, we couldn't find care that was based on science. Just couldn't find it. His parents told their friends, and our entire community rallied behind Mikey, that was his name, and their family. As you expect, I can remember it like it was yesterday. Parents coming to their home with cooked meals, driving carpools. The kids at our elementary school held bake sales on the weekends to raise money for Mikey's new charity for childhood cancer. But for us, it was different. I didn't tell hardly any of my friends what we were dealing with. Why? I was ashamed. I couldn't understand why my son wasn't trying harder. I was trying to figure out what I had done wrong as a father, why I had a son who couldn't resist getting high on drugs. And there was no response in my community, no cooked meals, no carpools. But even worse, the worst, when Mikey came home from treatment from cancer, he saw the bake sales on the weekends. When Brian came home from treatment, he just got silence. I think back and I feel horrible about it. When he came home once between treatment, one of his best friends was holding a party for graduating college. I said, Brian, go. It's like one of his best friends. He didn't want to go. I didn't get it. He didn't want to go because he was ashamed. And shame on me for pushing him. That was the difference.
So, Mr. Mendel, after Brian passed, did you put all of your business experience and business acumen to work, using all the skills that made you one of the most successful businessmen in this country? Did you put those to work trying to fight the epidemic and fight addiction?
It was a two-step process, but yes.
Tell the court about that.
In the weeks and months after Brian passed away, I started getting all these phone calls from people that knew Brian in the different treatment programs all over the country, crying, telling me that they should have died, not Brian. Because he had helped them. Because of the help he had given them, they were doing well. So I got the idea of starting a small local charity, which was my original vision. I had noted that Brian always did well in treatment, and then he would get out and relapse when he was in a halfway house. So I said, all right, I'm going to buy a house in Bridgeport, Connecticut, and see if I can help 10, 20 young adults a year run a really good halfway house. So I got back into my office the first few days of January 2012, and asked my partners to run the business for a few months. I just said, look, I'm going to get a small local charity going, hire somebody to run it, and get back to work in 4, 5, 6 months. Can you just guys run the business for a while? They said, sure. But as I began to research it, what I thought would be a small local charity, I started to, and this became my addiction, if you will. That's all I did. 15 hours a day, 7 days a week in the first months of 2012. Researching the field, the country. What was going on here? How did this happen? And as I did start peeling back the onion, I could not believe what I hadn't known when Brian was alive.
What did you learn?
I could talk for hours. If I had to summarize it, I would say that our National Institutes of Health had given out tens of billions of dollars of grants to researchers all across the country. And those researchers had successfully created a body of knowledge that had proven without any doubt through randomly controlled trials, programs you can put into our communities and our healthcare system to absolutely reduce the number of our family members who ever use drugs and ever become addicted.
Did you learn?
And one more thing, and another body of knowledge that would improve outcomes in treatment significantly, and about the shame and the stigma that was holding all this back. And then all of this was sitting so tragically in peer-reviewed medical journals, all in cyberspace. All the researchers knew about it, but it wasn't out in use in the public. As a businessman, seeing all this information that existed that wasn't being used, it was just unfathomable. And as a father, reading about information that could have saved my son's life, either preventatively or through treatment, or hundreds of thousands, if not millions of others, from having to bury a child? And all the stuff was sitting there in cyberspace not being used. It clearly became evident to me that this should not be a small local charity. That what our country needed was an organization similar in scope and influence as the American Cancer Society, American Heart Association, Susan Komen, Autism Speaks, for the disease of addiction. And with that, I decided to leave my business. The vision changed. I left my business and formed Shatterproof.
So at the outset of your testimony, I think this morning, I asked you if you knew, what an addict looked like, or if you knew anything about an addict. And you remember telling me you did not know, right?
Correct.
But after you began to research this, did you find out that addiction is a disease?
Yes.
A disease of the brain?
Yes.
And did you find out this wasn't just bad people doing bad things?
Yes, I read all the science, all the research, and it was clear that for some of those who use drugs, several regions of the brain change. And when those changes happen in the brain, for those people, and again, there's 3 forms of addiction. It's either slight, moderate, or severe. So depending on where they are on that spectrum, for those who are more moderate and severe, especially those severe, the changes in the brain can render them incapable of resisting urges, incapable of making a decision, following through with it, like the decision not to take a drug. And where I was really wrong, and I didn't understand, it wasn't about Brian or others saying, I need to take a drug to feel high. It was about taking a drug not to feel bad from going through withdrawal without medications. That's what it was about. It was us waking up in the morning, and if we had a bag over our head and we couldn't breathe, you'd be fighting not to feel good, but to be able to breathe. They wake up all day long, urges. Brian once, my son's funeral, my niece eulogized Brian. She told me a story that I hadn't heard before. She said, a few months before, he said, Jamie, having this is like having an itch in the middle of my head that I can't scratch all day long. That's what I learned.
I heard you say earlier you had an opinion on Brian's behavior, and you referred to him as just wanting to get high. Did I just hear you say that you were wrong about that?
Absolutely, you heard me say that.
So you said you wanted to create an organization like the American Cancer Society, but for addiction. Did such an organization exist in this country prior to you forming Shatterproof?
Not the scale of scope and influence of what those organizations, not even close. There were many smaller organizations that were not even in comparison to those organizations.
And you told the court you formed Shatterproof, and it's been around since, did you say 2012?
We launched launched publicly in September 2013.
Your Honor, can I display just the front page of the Shatterproof website while he describes what Shatterproof does?
Yes.
I have no objection.
Thank you.
Very. So this is the website of Shatterproof. Would you just tell the court, it says some of that on there, but just tell the court what Shatterproof did and what it does today, and what you're trying to do in the future.
Sure. We started out, if you look at what those organizations do, heart, cancer, autism, etc., they do 5 things. You can go through their financials and you'll see it. 1, they fund private research, gaps in research. 2, they work to change public policies, local, state, federal. 3, they work to ensure that research that's proven to work is getting implemented. 4, they reduce and/or end shame and stigma. And 5, they provide education, information, support, and hope to families. Those 5 things. So based on my background in business, it was clear that we weren't going to launch an organization and do all 5. So we started out with one of the 5, public policy. What makes me unique in this field is my background in business, and also my background in really understanding and relating really well, first to our investors in my business background and now to donors. And I wanted to be very clear that we're building an organization that was based on measurable results. And so I picked state advocacy, state policy work as an area that we can go in and get laws. We could take money in from donors. We could target certain laws in certain states and show our donors the impact we're having and reasonably estimate how many lives are being saved by the policies that we were changing.
You're running this just like a business.
Absolutely.
And you're basing your results on metrics and science.
Correct. And so we started out with state policy. We began that in 2014. To date, we've had policies changed in 16 laws, bills signed into law in 14 states. This year, we've doubled our budget, and we expect to have bills signed into law in 6 states. 3 have already gone through, have already been passed. They're waiting for governor's signatures. And that's our policy work. We've also been influential. We've grown our influence into federal policy as well. The last bill that was signed by President Trump in September, there were 2 clauses in there that were specifically influenced by us. That's our policy work. And then if you scroll down a little bit, just slightly on the website, you'll see right there. 2 years ago.
You're talking about the tell Congress it's time to treat addiction like any other disease part?
That's more the policy. I'm more the transforming addiction treatment.
Oh, I'm sorry. I looked at the wrong part. Transforming addiction treatment. What do you mean by that?
So 2 years ago, I developed a business plan to completely disrupt and improve the treatment system in the United States for addiction. It was a 5-part business plan. Number 1 was we needed one national standard of care for the treatment of addiction. The only thing that had existed in this country prior to this business plan being formed was the American Society of Addiction of Medicine placement criteria, which is not really a standard of treatment. It's detailed information based on a diagnosis, what is the right level of care. It's a placement tool, which is superb in a lot of ways. But it's not a standard of care. And so I looked at that, and what did I see? Very simply, from a business perspective, I saw 45 evidence-based processes that treatment programs should be following. Each one of the 45 had been proven in research and with published articles indicating the science behind why if you do this, the patient does better. You do this, the patient does better. So you had 45 evidence-based practices over here in my left hand, and even more shockingly, not even in my left hand, in different fingers, because they weren't even one place. They were all in different medical journals. And then over here, you had 14,000 specialty treatment programs outside the healthcare system, unregulated, all doing whatever they wanted to do, and no one had any idea who was doing what. No accreditation like hospitals that has the Joint Commission that accredits hospitals. Nothing like that over here with the 14,000 treatment programs. So to me, conceptually, this is simple to fix. There's not a business in America that is successful. I'm sure there's a few, but most businesses in this country who are successful don't bonus people on 45 different metrics. So I looked at this, and the Surgeon General's report was coming out a couple months later. I did a little research and found out who the lead author of the Surgeon General's report was a gentleman by the name of Dr. Thomas McClellan, who's been one of the leading researchers in the field for the last 4 decades, called him up and asked, after the Surgeon General's report was out, would he partner with me in taking one chapter of that report, the treatment chapter, and creating a plan to get it done. No more white papers, no more detailed reports that would sit in cyberspace. We had the report. It was going to be the Surgeon General's report. He said yes. And then we put together this business plan I was referring to. Number one, let's take these 45 and bring it down to less than 10 core principles of care that were understandable and unarguable, that every treatment program in this country should be doing, whether it's opioids or alcohol, whether it's adolescent, adults, inpatient, outpatient, every treatment program in this country should be doing these 8 things. Less than 10, And once we have that, then let's put 4 components, work streams underneath it to get it implemented. 1, a quality metric system. Get consensus on a quality metric system so we can gather the data to determine for these 14,000 treatment programs in this country, which ones are delivering what level of care of these 8 different or less than 10 components. 2, we need to change payment in this country. Payment is backwards. There's no There's less frequent prior authorizations if a doctor wants to prescribe Oxycontin or another opioid, and more frequent prior authorizations and limitations in place if a doctor wants to prescribe a medication to treat someone addicted. That all has to be reversed. Reimbursement rates have to be appropriate. Network capacity has to be there. So change the payment system. 3, provider training. We need to get it into medical schools. We need to get it into CEP, continuing education classes. We need to train the healthcare industry. And 4, we need to change the way that we think about this disease, reduce the stigma. Work streams. And now we are implementing it. We last September, I drafted with Tom McClellan and Pew Charitable Trust 7 principles of care that hit our goal of less than 10 that Dr. McClellan could represent. Were all representative of the Surgeon General's report. I was then successful a year ago last September of bringing into a room the 6th largest healthcare insurers in the country, and also a representative of the Association of State Medicaid Directors, and also the director of of the Association of State Health Agency Directors, and made a pitch to all 8 that yes, you can keep doing your own thing, but it's not working very well. But if you can all compromise on one national standard of care, these 7 principles. When I sit down, Tom McClellan's going to stand up and tell you, go through them one by one and explain why they're all represented based on decades of research, all summarized in the Surgeon General's report. If you can compromise it, then we can put together these 4 work streams, all based on these principles. Long story short, we were successful in doing so. 7 weeks later, after trading language a little bit, we were successful in getting 16 insurers, not just the big 6, but 10 others jumped on, representing 230 million lives, insured lives, on one set of our national principles of care, which is in there if you wanted to dig down, but we don't have to now. Each of those insurers signed a document committing to our principles, and in that document also agreeing or committing to identifying and rewarding care consistent with our 8 principles of care. I say 8 because we added another one in that back and forth process, screening. So now we have 8. Once that was done, we began implementation of those 4 other work streams. I scoped out a business plan to build a quality metric system in this country that was based on recommendations made by the National Institute of Medicine, National Academy of Medicine, back in 2006, but it wasn't implemented. We scoped out a project to build this and pilot it in 5 states, and we received $4.7 million in funding, which is what we needed to do it last fall from some of the largest foundations related to healthcare in our country. And we're now a year into the two-year process of building it and launching it. Payment reform, we're getting policies changed all over the country to the way they pay for it and add to provider capacity. And then stigma, we are in the process of building a comprehensive plan for this entire country of how stakeholders in all segments of the country can plug in and be our partners in a framework to reduce the stigma all over this country. The stigma, everything I've talked about to date is related to substance use disorder, all drugs and alcohol, except for our stigma initiative. We're going to start out with the stigma related to those addicted to opioids and grow from there. And there's 3 types of stigma. There's social stigma, what the public feels or believes. There's self-stigma, with those who are addicted and their immediate family feels. And there's structural stigma, systems, our criminal justice system, our employer system, our healthcare system, our higher education system, universities and high schools, what policies do they have in place? So we are going to be finalizing our plan in the next couple months, which will have those components related to public stigma, self-stigma, and system stigma, each of those components I mentioned. And best practices that those who want to participate can do so following evidence-based practices, what has proven to work with HIV/AIDS, what proven to work with reductions in stigma in mental health, what's proven to work for reductions in stigma to marriage equality, what's proven to work for domestic violence. And taking those, we've actually identified 90 published articles that have, with research that's proven to work and all those other social changes, summarized each of those, made a set of hypotheses of what we will do with our plan. And now we're going through 40 individual expert interviews, which we're about halfway through, with social change experts and addiction experts to test our hypotheses of, are we attacking the right channels and our action steps, in their view, right? Should we tweak them, etc. And once we finish those interviews, we will then publish this and begin recruiting execution partners in each of these domains.
Mr. Mendel, you approached this just like you built your hotel business up.
Yes.
Just like a business. And you've taken on trying to attack the epidemic of addiction nationwide, correct?
Absolutely.
And in the last 7 years, I think you told the court you immersed yourself in the science of addiction and read day and night. Have you done that for the last 7 years?
Yes, although I would rephrase it a little bit, is I am very focused on solutions to 2 different populations. The 5 million who are addicted to opioids, 3 to 5 million that are addicted to opioids. The other 15 million that are addicted to alcohol and or other drugs. Call that a population of 22 to 25 million. That's one segment. And the other segment is our 300 million plus Americans who are not addicted yet. And how do we prevent them from becoming addicted? And our children, and our grandchildren, and our great-grandchildren, and future generations.
So, Mr. Mendel, in the last 7 years, would it be a true statement that you have acquired a great deal of experience and specialized education and training, self-taught for the most part, in the field of addiction?
Absolutely, although I would rephrase the word self-taught. Self-taught, yes, but through the help of so many others. I regularly speak to experts all over the country. So self-taught when I'm reading research, not self-taught when I'm speaking to experts about what the research I read and I'm asking them questions and they're teaching me. And there's just wonderful experts all over the country who are just dying to help.
So you've essentially gone to school for the last 7 years in this field.
Absolutely, on solutions.
Well, let me ask you this. What is the Presidential Commission on Combating Drug Addiction and the Opioid Crisis?
It's the President's Commission, I think, but that was a commission set up by Governor Trump in early 2016.
President Trump, you mean? You said Governor Trump.
Oh, did I? Really? I'm sorry. Yeah, President Trump. And it was headed up by Governor Christie. That's why I said governor. And he brought in 5 others to form this committee. And they were charged with studying all the different ways to abate this crisis in this country, specific to the opioid crisis, and come up with a set of recommendations, which is what they did over a 9-month period.
And have you worked on that issue of abatement?
In their, they held a series of hearings, and in the first hearing, I was one of the experts called on to testify.
And did you testify to the President's Commission on Combating Drug Addiction and the Opioid Crisis as an expert?
I testified in their first hearing in June, and then I regularly communicated with Governor Christie and his chief of staff and some of his policy people between the testimony and the issuing of the final report, continuing to educate them on my recommendations.
And have you continued to meet with the chair of the President's Commission, Governor Chris Christie, from time to time?
Sure, we have kept in touch. We've seen each other at a few. I was at the White House when the President signed the Support Act. No, I'm sorry, when he announced it as a public health emergency. I saw Governor Christie there. I actually spent 2 hours with him last week. He has a very strong interest in this area, talking about ways that he can, running by him everything we're doing and see if he had any advice, and also ways that he can continue to stay engaged in this topic, working with us.
Your Honor, can I approach?
Yes.
This is an exhibit to your deposition. Would you tell Judge Bachman what that is?
My testimony was in 2 forms, both verbal and written. This is the written form.
So are those the recommendations that Shadowproof made to the President's Commission on Combating Addiction and the Opioid Crisis?
Yes.
Your Honor, we'd like to make that a court's exhibit. I don't know what the number is, but I would offer that just as a court's exhibit so you can see what he has done in terms of qualifying him.
I don't think it's on the exhibit list, Your Honor. I don't know what
if it
he
is or
plans
not.
to do with it, but if it's just for purposes of qualification,
It is.
it can be marked as a court's exhibit.
It is.
I will accept as a court exhibit 78 the
Thank you, Your Honor.
recommendations from Mr. Mendel.
Thank you, Your Honor. And since the time you made these recommendations to the President's Commission, have you also been asked to testify at the National Academy of, I'm struggling to remember.
It's okay,
what-
National Academy of Medicine. I'm not sure if I would use the word testify. The National Academy of Medicine,
What is the National Academy of Medicine?
it's an institute that continually does research on different areas within our healthcare system and disease states. And last year, they formed a collaborative related to the opioid epidemic. And it's a 2-year process. They formed working groups with experts in each of the 4 areas. 1, pain management. 2, prevention, treatment, and recovery. 3, data. And 4, healthcare systems. They formed working groups of experts in each of those areas. And the working groups meet regularly by conference call, and they had their first in-person public meeting on April 30th, 6 weeks ago.
And what did they ask you to do at that meeting?
They asked me to be the keynote speaker at that event to educate them on number one, everything that Shatterproof is doing, and two, make recommendations. They asked me to review what each of the 4 working groups were doing and see if I thought they were missing anything.
And what kind of people or what kind of organizations were present at the National Academy meeting where you were the keynote speaker?
We can go through their website and look at all the logos, but this is the institutions of the United States related to health. Assistant Secretary Admiral Gerard was there, who spoke for a few minutes just before me, who's the Assistant Secretary at HHS that oversees the opiate epidemic for Secretary Azar. CDC is there, AMA, I mean, any organization in this country that is well-known, well-credentialed in this space is part of this collaborative.
And do we actually have a list on the website that we're prepared to show the court of who was there when you were the keynote speaker?
Sure.
Your Honor, may we display the list of all the attendees just to give you an idea who was there?
I don't have any objections.
Yes, you may.
Mike, can you do that? Let's kind of scroll through that. Are those the organizations?
Yes.
that were
Yeah, though I would rephrase it, I'm not sure that each one was in attendance. Each one is a member organization. There are 100 member organizations. But I suspect each one was either there in person or by webcast, and it was webcast live all over the country.
And Mr. Mendel,
But each one of those are part of the working groups, that's for sure.
Can we have this marked as a court exhibit as well when Reggie has a chance to stop?
Yes, we will.
Thank you.
Later this morning, we will make a record of both this website as a court exhibit and also the Shatterproof website that was
Thank you.
showed earlier.
Thank you. Maybe Mike and Cynthia, you can help me print those things out later this morning. We'll get that to you. Your
Thank
Honor.
you.
Thank you, Larry, for reminding me. So, Mr. Mendel, becoming an expert in this field, is that something that you wanted to do? Or did you?
I don't think about me becoming an expert as any criteria that I think about. What I think about is taking the research that we have, tens of billions of dollars of research that was funded by our federal government, that exists today, and getting it implemented. And getting it implemented structurally within our system so it continues to improve and iterate year after year, decade after decade. So our children and our loved ones are prevented from developing a disease where research has already proven methods on how to do that. It's implemented. So those who are addicted with a disease, who have a substance use disorder or an opiate use disorder, are treated with the latest science. It's built into our system. And we eliminate the shame and stigma, which holds both of those back.
Did you ever think you would be doing this before Brian got sick with this disease?
No, and shame on me, because I should have.
Well, let me ask you this. Today, are you recognized as an expert in the field of addiction and specifically how to fix the addiction problem and the opioid problem in this country?
I'd answer that by saying it's not my opinion that I am. The fact that I was asked to testify in front of the Presidential Commission, the fact that I was asked to be the keynote speaker, the one and only keynote speaker at the National Academy of Medicine on reviewing each of their 4 working groups and see if they were missing anything, and inform the group of everything that we were doing so they can learn from the things that we were doing, and secondly, providing any recommendations of stuff of anything I thought they were missing, I think indicates that.
And do you feel personally like you have acquired a great deal of expertise in these fields up to today?
Yes, but I would also add and say that I'm not an expert researcher. I'm not an expert scientist. The perspective that I bring is a business perspective, and that's what makes me unique in this field.
Is your specialty?
The quality metric system that we're building right now, that we just got funding for last fall was sitting in an National Academy of Medicine report with every expert, numerous experts drafting that report back in 2006. It was my skill set that came in and put together a plan to get it done, to execute it, implement it, pilot it, and with the goal of then spreading nationally across this country.
And have you built up expertise in solutions?
Absolutely.
And have you built up expertise in solutions to the opioid epidemic?
Absolutely.
And are those contained in the recommendation to the President's Commission on Addiction and the Opioid Epidemic?
Some of those.
Okay.
That was a particular audience. That was geared toward A, what the federal government can do, B, with a lens that when I was drafting this, of a limited number of big things, because the government is not going to do 24 action items. What were the key things? What was it when I drafted this? What was in my head is, A, this is the federal government. B, I need to simplify this into key things, a few things the federal government can do. And so that was the lens on which this was drafted. And I was looking for things that didn't cost money, because that would run into another roadblock in Congress. So what were the things that could be done with little money or no money? And that was the lens this was created.
Yes, and you're looking at the whole country and the federal system and things of that nature, right?
Well beyond the scope of what the federal government can do, yes.
Yeah. And I've asked you to look at something a little different. We're talking in this lawsuit about just the state of Oklahoma. Have I furnished you with a written copy of the abatement plan in this
Yes.
case? Your Honor, at this time I would move that he be qualified as an expert witness and offer a few opinions on the abatement plan.
Your Honor, this was subject to a previous motion. I know Your Honor remembers that. We would just reassert that at this time for purposes of qualifications and expert testimony.
Thank you, Mr. Ottaway. And we did. We had a hearing where I considered the defendant's motion in opposition, and consistent with my previous ruling, I'm going to overrule the defendant's objections and
Thank you, Your Honor.
thank you, Mr. Mandel, to offer expert testimony.
Thank you, Your Honor. Mr. Mandel, just so you know, there have been, we're presenting this abatement plan in various phases, different witnesses, Dr. Kolodny, Dr. Beeman, Jessica Hawkins, Terry White, Julie Croft. They're all going to talk to the court about dollar figures and things of that nature. I want to ask you about the components of the plan, the line items, and you've looked at all those.
Yes, I have.
And can you tell Judge Balkman your opinion on the various line items that the state of Oklahoma has suggested in the abatement plan, and tell the court whether you think they are reasonable and necessary, please, sir, based on all of your experience?
Sure.
Excuse me, Mr. Mandel, I'm sorry to interrupt. Just a
Okay.
second. Your Honor, if you remember at the hearing when we had our Daubert motion, I asked you to stick a pin in an item, and I'd like to bring it up now. At the time of Mr. Mandel's deposition, he had spent about 45 minutes with the state's plan, which was Exhibit S to his deposition, and was not ready to render opinions as he's going to render today. I brought up the fact that I thought that was not the way things work in a court of law, that we were able to know his opinions so I could cross-examine him. I'm perfectly happy to point out the parts in his deposition where he said he was not prepared at that point to give opinions, but planned to study on it and would be prepared when he came up to testify today. I'm just re-urging that because I have no idea what this testimony is going to be, even though his deposition was taken just 60 or 90 days ago.
Well, Mr. Ottaway, I'm going to give you the opportunity to cross-examine Mr. Mandel, and you'll be given that opportunity to test his knowledge and find out if there's any concerns that you have with regards to his recollection or his knowledge about the abatement plan.
I appreciate that, Your Honor, and I know you'll give me that ability. I just want to raise the fact that I'm kind of flying blind in it because he was not prepared to give those opinions at the time of his deposition.
I'll note your objection.
And may I just say briefly, Your Honor, for the record, Larry wasn't there at that deposition. I was. And indeed, I took many of the depositions of Johnson & Johnson and their experts also said they reserve the right to do additional work. So he's flying no more blind than I am. And nobody asked to take a supplemental depot, and I would have let them. But I think you're going to find, Larry, that none of this is going to change anyway.
I appreciate that, Mr. Whitten. This wasn't a question of a supplemental deposition being needed or somebody doing additional work. This was a question of no work having been done at the time of the deposition.
Well, that's not true. But may I continue?
You may proceed.
Mr. Medell, the line items themselves in the abatement plan, would you tell the court about whether you believe that they are reasonable and necessary in the state of Oklahoma to abate the epidemic of opioids that we have in this state?
Sure. I have gone through each of the line items, and I absolutely 100% agree that each of those line items are needed and necessary.
Indeed, are they consistent with the national recommendations that you made to the President's Commission on Addiction and the Opioid Epidemic?
Not exactly, because it's through a different lens.
Explain, please.
To the President's Commission, it was what the federal government can do.
Right.
And again, it was also through a lens of, through a lens of what the federal government can do. It was also through a lens of a limited number of items, because I know the federal government is not going to do this comprehensively. There were going to be a few things they were going to pick out, so I was focused on a few items. Number two. And number three, I was also focused on items that would not cost any money, because I knew that I would run into roadblocks getting implemented through Congress.
And the state of Oklahoma doesn't have those limitations in this epidemic, or this abatement plan?
Not that I'm aware of.
All right, sir. So those items are reasonable and necessary in your opinion?
In the exhibit, in the report that I read, the abatement plan, absolutely each line item is 100% I believe in. Every line item, my experience and my knowledge says each of those are needed. There's one, I spent time on each one, thinking about each one. But I also scanned the numbers on the other column, which I'm not here to testify about the cost.
Let's stop right there. So the other column, we don't have it right in front of us, but those are the dollar figures.
Yes.
And as I understand it, you're not providing the actual dollar figures except for one line item that we'll talk about in a moment.
Correct.
Is that correct?
That's
We'll have
correct.
actually, we've had several other witnesses have already supported the dollar figures, but you're supporting the line items themselves. Did I say that right?
You did, yes, correct.
Now let's talk about the one line item that you did have an opinion on, stigma reduction. Let's talk about that. Did you have an opinion on the dollar figure that the state's abatement plan recommended for stigma reduction? And if so, please tell the court what it is and why.
Sure. Well, the line item is called public education. It's one of the sub-exhibits. And in that, when you go to so it says public education on the cover sheet, on the aggregate listing of all the initiatives that are needed. And then when you go to the sub-schedule that describes, it was about $26 million that was shown on the summary sheet for public education. So I went into the sub-schedule and to see the detail on how that $26 million was going to be spent and what were the initiatives they were focused on related to public education. And it simply just had a paragraph listing the areas they would spend that money on. And one of those was listed as stigma. It was listed about educating the public about the risks of opioids. Stigma was listed. Educating the public about what treatment works. Educating a healthcare system about pain management and treatment. It listed 6, 7, 8 items in a paragraph format. And one of those was stigma. And then it just says total $26.5 million, next year 25, and then it goes down from there. And when I saw that, it was actually, that popped out to me as a number that is woefully low. And coincidentally, when I was at the National Academy of Medicine, educating them on and walking through the initiatives of Shatterproof, and they asked me, they asked me to review the work of all the 4 working groups, of each of the 4 working groups, and see what's missing. The one recommendation I made that was missing in the work of the National Academy of Medicine, there was nothing in there for stigma reduction. And unless we significantly reduce the stigma, both socially, both to self, those who are addicted and their immediate family, and structurally within the systems of employers, healthcare system, education. I'm missing one big one, criminal justice system, etc. We're not going to get close to maximizing the dollars we're spending in all these other areas. That's what I recommended to the National Academy of Medicine, and that popped out again when I saw this exhibit, that woefully underestimating the impact that we will be missing if we don't change the way the public and each of these systems and self think about this disease.
When you were meeting with the chairman of the President's Commission on Addiction and the Opioid Epidemic, then Governor Chris Christie, did you discuss stigma reduction and how much was needed with Governor Christie?
When I testified at the hearing, it was a paragraph, I believe, toward the back here, because it's soft, and I didn't see the federal government being an effective leader in this area, but I did list it as one of the areas because I didn't want to leave it unsaid. But Governor Christie, when I met with him last week, it's one of the areas we spoke about of what states can do to reduce shame and stigma.
And what did he say about the amount that New Jersey was spending on stigma reduction?
He's not aware of what they're spending today, but his last year in office, they spent $40 million in that last year of his last year in office, running a public education campaign, primarily directed toward social and self-stigma, not even touching the structural stigma, which is the biggest one when you think about the healthcare system, the employer market, on and on.
So you thought Commissioner White's abatement plan was a little light on stigma reduction, but other than that, you would embrace all the concepts in the abatement plan?
Yeah, though I would rephrase that. Her line item is public education, of which stigma is one of the 5-6 items listed, and in the aggregate, woefully low, not a little light.
Okay.
Mr. Whitten, I know we don't have Commissioner White's abatement plan entered into the evidence yet. I know Mr. Stone, when he testified, there was an exhibit mentioned. Do you have an exhibit number just so I can reference that?
I was actually going to call Commissioner White as the last witness and introduce it at the end. We've kind of been doing pieces.
Well, at least the portion that was introduced with Mr. Stone, because I believe it included the public education component.
It does, and Your Honor, in omission, I think the abatement plan itself was not listed by the plaintiff, but it was listed by Johnson & Johnson. Johnson & Johnson exhibit is 2026. I would like, since they listed it, I would like to offer that I was going to do it during Commissioner White's testimony, but asked that we put a state's exhibit on there. And I don't know what the next number is, but we can do that.
But do you know the exhibit number that was referenced during Mr. Stone's testimony?
Yes, I can find that out, but that wasn't the whole plan.
Right, that was just mostly the marketing, but I think
yes,
as my memory goes, I think he also touched upon public education for stigma. Maybe I'm wrong, but I thought
I
there were
don't
some
remember,
components.
Your Honor, and I hate to guess. May I go ahead now? I don't
Sure,
have
you
a
don't have to
problem.
get it to me right this minute.
May
but
I
just-
get the latest, what is the last number? I'm happy to offer the entire abatement plan. We just haven't talked about all of it yet, but we'll do it through different witnesses. May I offer the entire abatement plan now? They've listed the whole thing as JO 2026. I'd like to make it state 4734, And that covers the whole thing, if that's okay with the court.
Your Honor, we would object to the introduction of the entire abatement plan at this point, putting cart before horse, as it were, since it has a lack of foundation. But I will get you the exhibit number of the item that was offered with Mr. Stone's testimony so that we can put that in your notes at the break.
Yeah, I'm going to sustain the defendant's objection. Certainly, I anticipate that in future testimony, you'll have an opportunity to lay a better foundation, but
That's fine. I actually wasn't intending to offer it today, but since you brought it up, I thought I'd try it. But I'll do it. It's your fault, Your Honor.
nice try.
I'll come back and I'll introduce it through Commissioner White, and we'll probably just refer to it then as 4734 if my team will help me remember that. And Your Honor, those are all the questions that I have for Mr. Mendel. Mr. Mendel, thank you, and I think Mr. Ottaway's going to have a few questions for you.
Thank you.
Would you like to take our morning break now?
Why don't we just go ahead and do that? What do we have, 10:25? Let's break until 10:45, all right? Mr. Ottaway, you may proceed with your cross-examination.
Thank you, Your Honor. For purposes of the record, I will make an offer of proof on the objection I offered originally, and I will offer into evidence or as a court exhibit, page 101, 117, 119, 129, 131, and 137 of Mr. Mendel's deposition. But we can do that at a break, so.
If we're going to do that, I'd ask the whole deposition be marked under the rule of completeness.
Well, I'm only making a record on the fact that Mr. Mendel was not available to answer questions about his view of the abatement plan, and that's all I'm offering it for.
It
So
needs to be put in context under the rule of completeness to see they ask all the questions they wanted, so the whole thing ought to be marked.
the rule of completeness applies to documents being offered into evidence, not offers of proof. So-
Mr. Ottaway, are you making an oral offer of proof, or are you going to?
I'm just pointing out that I will offer those pages to Your Honor as an offer of proof at the next break.
Okay, you may do that.
Thank you.
And Mr. Whitten, you'll certainly be allowed the opportunity to respond either orally or in writing if you feel that it's not complete. Thank you.
Sorry for all the legal jargon, Mr. Mendel. I didn't mean to hold your testimony up, and thank you for coming to talk to us today.
You're welcome.
I know this must be repeatedly painful for you because you speak a lot around the country about your family's experience. But if I might just ask a few questions about your personal experience?
Sure.
Is that, do I have your permission to do that?
Absolutely.
All right. As I understand it, your son's experience with prescription opioids dealt with Vicodin and OxyContin.
And heroin.
Prescription.
Correct. You are correct. And correct.
But those Vicodin and OxyContin were not prescribed to him, as far as you know.
Well, that's not true.
Okay.
When he had wisdom teeth pulled, he was prescribed a prescription opioid. I think it was Vicodin. And I remember my wife looking at it and saying, was shocked that the doctor who pulled his teeth is a family friend, knows our history, knew Brian's history, still prescribed him a full bottle of prescription opioids. And I'm pretty sure it was Vicodin.
The reason
And so
I asked,
that was number one. Number two, when we searched Brian's car one time, I found a bag, a little brown bag, and in that I saw in the prescriptions that are written by doctors off a pad. There were several written by different doctors for prescription opioids. Now, whether they were filled or not, I don't know. But that wasn't. I mean, that was in the heat of his addiction. That second time that I'm referring to. The first time was simply having wisdom teeth pulled.
you can understand my confusion. May I approach her? And I only have one copy. I'll go to
Yes,
page
you may.
147, line 5. Do you have a copy there, Reggie?
Yes, sir. Thank you.
Okay, you got it?
Thank you. What page?
147, line 5.
147. Sure.
Okay, do you know if it's prescribed by a doctor? I don't think. Okay. I understand that he had taken Vicodin. Do you know if that was prescribed by a doctor? I don't think so. He had been prescribed by a doctor. Yeah.
Okay.
He had been prescribed Vicodin, prescribed by a doctor one time when he had his wisdom teeth. Is that consistent?
Yeah, I'm going to ask you a question.
Okay.
Okay. And the reason I asked you, Mr. Mendel, about that was because we asked that question at your deposition, and I just showed it to you.
Sure.
And let me ask if these questions were asked and this answer given, okay?
Sure.
We just went over it. You have a copy there in front of you.
Yeah, sure. What page?
It's page 147, line 1 through 8, and
Okay. I have it.
you got it there?
Have it in a second.
Okay.
Yes.
You got it there? Okay. Question, it's my understanding he had taken Vicodin. Question, do you know if that was prescribed by a doctor? Answer, I don't think so. He had been prescribed Vicodin prescribed by a doctor one time when he had his wisdom teeth pulled, but that wasn't the cause of it. Was that the complete answer you gave them?
That's exactly what it says.
Yes.
So I'm looking back to say that, but that wasn't the cause of it. So what was, I'm trying to understand the context of me describing that. But in any case, the fact is, I'm not sure what I'm referring to when I say the cause of it. So I don't know I have to go back and read it to see what I was referring to. But the facts are, when he had his wisdom teeth pulled, there is no question, God bless you, there is no question that he was prescribed a prescription painkiller. I'm pretty sure it's Vicodin, but we can certainly go back and check if it's in the records. And there's no question my wife looked at that bottle and was shocked at the amount of prescription opioids he was prescribed. I can remember it like it was yesterday, I know right where we were standing. And was shocked that our friend, who is a doctor who knows Brian's history, prescribed to him that amount of prescription opioids. That's a fact.
Okay. Anything else you need to say about that?
Not that circumstance, but also I'm not sure if I mentioned in this deposition, because I just thought of it in the last couple of days, that time we found some prescriptions in a bag in his car, but again, I'm not even sure if they were even filled.
And did you follow up on those to see whether those were legitimate prescriptions or?
I did not.
Okay. And he had no prescription for OxyContin that you're aware of?
Not that I'm aware of.
All right.
That I can remember right now, no.
The reason I'm getting into all this is I'm going to ask you about two specific things.
Sure.
Do you ever remember him taking either Nucenta or Duragesic?
I don't.
Okay.
Again, I'm not saying he didn't, but I don't recall.
Yeah. Well, all we can do here is do the best we can.
Sure.
He did, however, take Xanax at some point, and that was prescribed.
Yes.
Xanax being a benzodiazepine?
Yes.
Okay, we can put those away. I'm sorry I had to ask that.
That's okay. You can say anything you like.
Now, as I understand it, you have brought some business expertise into this area of abatement, correct?
Yes.
And you often talk, I think, about something you call high-impact solutions.
Yes.
And I take it those are the kinds of solutions that make the most difference in the least amount of time?
Well, when we say high impact, it's those solutions that will have the greatest impact on the result you're trying to achieve. I wouldn't qualify it with that qualifier that you added.
Okay, just the most bang for your buck, if you will?
Well, again, if you say high impact, it's not biggest bang for your buck, it's biggest bang.
And when you talk to the
And let me add to that, if I can. If you don't want me to, I won't. But
No, you go ahead and say whatever you want to say.
if you're dealing in strictly economic terms, put aside the human emotion of having to bury a child, whether it's my child or anybody's child in this courtroom, and you put that aside for a moment. There happens to be this epidemic in this country right now that not only do the solutions make sense to prevent having to bury a child, but there's huge return on economic return on investment on the solutions, because the cost to society is multiples more than the cost to abate it.
I'm glad you brought that up because that's exactly where I was going.
Okay, good.
Because I had read your shatterproof stuff here. And in fact, you talk about how the return on investment means that the government will, or society will, come out ahead if we do certain things, correct?
Absolutely.
Now, I want to talk to you about a couple of those things, Mr. Mendel.
Sure.
Great. Some of those things are things that and you have recommended that the government do, correct?
Yes.
And at least in terms of the Christie Commission that you talked to Judge Bachman about, most of your recommendations do not require the expenditure of a single penny, do they?
Yeah, but there's a big point that I want to clarify for the court. Those recommendations, most of those recommendations that don't cost a penny, they were based on the leverage of the federal government. There's many things that need to be done at a local and state level that, through our democracy, take time to implement. And my big point to the federal government is President Nixon, look, back up, because this is a basis, and I think it's in the first paragraph or second paragraph of my written recommendations to the President's Commission, was I don't believe that our federal government exists to overregulate and over-legislate. That we have a big country with local governments and state governments, and the federal government should not be overreaching, creating laws and regulations that have to be checked and rechecked and rechecked to see if they're occurring. Give power to the local communities and the local states. That's the way our country works well. Having said that, there's certain points in history where the leverage of the federal government, in my view, can be used to speed things along that would happen naturally over time through our democracy. For example, and I list it there as an example in that written report, President Nixon knew that it was better for our country if the speed limit was reduced to 55 miles an hour on our highways. He didn't, as a Republican, but Republican or Democrat, he did not want to over-legislate our country. He did not recommend passing a law that required every state to limit their speed limit to 55. He did it the right way, in my view. He said, states, do whatever you want. But if you want federal money for transportation, I'm only going to give it to you if you, on your own, maximize your speed limit at 55 miles an hour. So my recommendations, and I say that right in there, are based on what President Nixon did. There are certain things that states can do and communities can do. If you want federal funding for the opiate epidemic, my recommendation is the federal government not over-legislate states, but condition federal funding that goes to the states on certain things being done. That does not cost the federal government any money, but certainly lots of money needs to be spent throughout our country, whether it's states, whether our healthcare system, etc. Lots of money needs to be spent. So I want to make sure that's clear. Just not by the federal government to use its leverage, and we're giving out billions of dollars. Let's condition that on certain things being done at the state level.
Would one of those things be, for example, adopting Medicaid expansion under the Affordable Care Act?
I don't remember if that was one of the things that I put in that report or not. It was 3 years ago. I can look and read it, or you can tell me if I said that.
Do you remember saying in the past that adopting the Affordable Care Act, Medicaid expansion, would take care of 90% of the treatment costs dealing with addiction?
No, I think what I may have said, I don't remember ever saying that, but I suspect I may have said that in states that are Medicaid expanded, you combine that with the other forms of financing that are within the system, that should take care of the vast majority, but not all, of the cost of treatment. I have said something similar to that in the past.
Said it right here in Oklahoma?
Excuse me?
Said it right here in Oklahoma.
I don't recall, but I'm not saying I didn't.
And has Oklahoma accepted Medicaid expansion?
That's my understanding they have not.
Okay. Another thing that we talk about as a potential high-impact solution is the efficient use of PDMPs, correct?
Yes, it is.
Can you not tell Judge Botman, remind Judge Botman, because we've had testimony about it here already, what a PDMP is?
Sure. A prescription drug monitoring program is every state has one of those except for the state of Missouri. And it's a state database of all the narcotics that have been dispensed from pharmacies in that state, by record, by person, and by pharmacy. And they were created decades ago to be able to track the movement of narcotics throughout that throughout the state to look for diversion. Well, Kentucky realized, again, this opioid epidemic is new.
I don't mean to cut you off, Mr. Mendel, but all I ask you to do is to remind
Oh, sure.
Judge Botman what a PDMP
Okay, that's what a PDMP is, sure.
Thank you.
And your state has one, New York.
Every state has one except the state of Missouri.
And so the answer to my question is yes, your state has one, New York.
My state's Connecticut.
Connecticut, okay. New York has one. I'm sorry, I got you in the
It's
wrong
okay.
place.
It's
I
okay.
apologize.
My office is in New York.
Okay, well, give me that one then, will you? All right. And they adopted the PDMP in 2013?
Well, no, in 2013, New York made it mandatory for every doctor in the state, before they considered prescribing an opioid, to check the database to see what else that patient has been prescribed.
And they made it mandatory for every prescription?
Every prescription
And that is
of an opioid.
yeah, that makes best practice in your judgment?
Yes.
Do you know when Oklahoma made its PDMP mandatory?
I am not aware if they have or they haven't yet. And again, when you say mandatory, would that, just for the court to understand, mandatory for prescribers to check it, which takes less than a couple minutes, if even that, to see what else that person has been prescribed. And if they do that, there's information they can learn about the patient before they make a decision whether to prescribe what the patient is calling for or not.
You remember I talked to you a moment ago about speaking in Oklahoma?
Yes.
And did you learn at that speaking engagement that Oklahoma did not make its PDMP mandatory until 2015?
I don't recall.
Did you learn at that speaking engagement that the prescription of an opioid only has to be checked every 6 months?
I don't recall, but if it's every 6 months, that does not meet best practices.
All right, thank you. Another thing you've talked about as something needed, you have talked about the 2016 Cdc recommendation,
Yes.
and how that if people would simply implement those, it would make a big difference in prescribing practices.
Absolutely. Yes.
In fact, you said that could be done fairly quickly, have you not?
I have said that if the federal government conditions funding on states to require their prescribers to take a course in the CDC prescribing guidelines and then adopt it as their standard of care, then prescribing, the amount of opioids being prescribed would go down quickly.
And do you know whether Oklahoma has done that?
There's no state that has done that.
So Oklahoma has not done
It's not that I'm aware of.
All right. One of the
And let me rephrase the other one. I'm not aware of any state doing that. I can't say for sure.
Thank you. And feel free if you need to
Sure.
comment. I'm not trying to limit your testimony here,
Sure.
really. One of the CDC recommendations, for example, is a requirement that if someone is on Xanax or benzodiazepine and an opioid, that be recorded, correct?
Yeah, there are 12 recommendations in the CDC guideline for the safer prescribing of opioids. 12 recommendations. Recommendation number 9 is that prescribers check the database before they consider prescribing an opioid. Recommendation number 11 is avoid, in almost any possible circumstance, the co-prescribing of an opioid and a benzodiazepine.
And that's because a large percentage, maybe I think 40%, according to you, of the deaths involving opioids also involve concomitant use of a benzodiazepine, correct?
It's my recollection is 30%, not 40%, but a large number.
Okay, 30, I'll accept your number, Mr.
Sure,
Mendel,
either way, it's a
30%.
large percentage.
Have you gone back to look at the state's history about whether in its Medicaid program it has required an edit that would tell the state whether there is concomitant use of benzodiazepines and opioids?
Have I done that in the state of Oklahoma?
Yes.
No.
So if you were to learn that that was first brought to the attention of the state in 2002, and that as of 2018 that had still not been done, that would not be best practices either.
Tell me again what exactly the request would be of the state?
Well, as I understand it, your statement here is that they should check for concomitant use of benzodiazepines and opioids, correct?
They meaning every prescriber before they consider writing a prescription for an opioid. That would be best practice, yes.
And if the state hasn't done that in its Medicaid program, that would not be best practices, correct?
Well, I'm confused because that's not a Medicaid program issue. That is a prescriber.
Well, I'm limiting it to the Medicaid program.
So if I understand it, you're saying to get reimbursed through Medicaid,
Correct.
doctors would have to check a box that they have checked the prescription drug monitoring program first to see if there's or the patient's already being prescribed a benzodiazepine? Is that your question?
Yes, before prescribing an
Yes. So yes, I understand it, and yes, that would be a best practice. And so yes, if Oklahoma, to answer your question, is not doing that, then that would not be, they were not conforming to best practices. Although, let me qualify that to be exactly accurate. We published March 30th, in the last couple days of March 2016, a publication that was best practices for effective use of prescription drug monitoring programs for states. One of those 12 recommendations in there, so we had 12, the CDC had 12, not to be confused, was requiring prescribers to check the database, the prescription drug monitoring program, before they make a decision of whether to prescribe an opioid or not. We did not list as a recommendation that any particular payers require that, whether it's a commercial payer or a Medicaid payer. So I was incorrect in saying if Oklahoma's Medicaid is not doing that. I have not seen that documented. It's certainly not documented in our best practices, and I have not seen that documented anywhere. So I take back the statement that Oklahoma would not be following best practices if that was by Medicaid. Having said that, intuitively, of course that would, not of course, intuitively, I believe that would be a help.
Thank you. Now, when we talk about high impact solutions, you talk about having reviewed the state's abatement plan, correct?
Yes.
And unlike the plan that you offered recommendations on to the federal government, this plan involves the expenditure of money.
Yes.
In fact, really, money wasn't even considered. It was kind of everything you'd want and the cost of it in the abatement plan, correct?
I didn't put that together. There's no way that I can opine on the fact that
And
money
you
wasn't
didn't.
considered.
I'm sorry, I didn't mean to. And you didn't do an abatement plan yourself, did you?
I did not.
But when you looked at the state's plan, you saw, in fact, I think you commented in the one line item that you discussed, that it went out a number of years.
Yes.
In fact, I think it was, do you remember whether it was 20 or 30 years?
I I can't say specifically. I think there was, the plan had 3 different levels. I think it was either 15, 20, or 25 is what or close to that.
And you have spoken on this issue before, haven't you, of what it would take and how long it would take to make a difference in this abatement of the opioid epidemic.
What I have, when I speak, depending on the audience, but usually with any audience, you have a short amount of time to speak and to get concepts across. So the concept that I present in my remarks often is conceptually the point I try to get across to audiences. This is not about spending tens of billions of dollars for a rare form of cancer to hopefully come up with a vaccine 30 years from now that'll end that disease like polio or some other disease. This is about taking the research that we already have existing and getting implemented. If we take the research that already exists and get it implemented, we can reduce this epidemic dramatically, quickly.
And that's what
That's
I
the
want to
point.
talk. Yeah, that's what I want to talk to you about, Mr. Mendel. We talked specifically about amounts spent for stigma reduction. Do you remember that?
Did I say today or
Today.
earlier? Sure.
Today.
Yes, of course I remember that. Yes.
Okay,
Yes.
thank you. And you have spoken about that before, have you not?
Yes, I have.
And you have not indicated in those speaking engagements, for example, that it will take 20 or 30 years to do that, have you?
I haven't won my most recent one because what I've been doing for large amounts of time over the last many months has been reading those 90 published articles that I mentioned about what worked and didn't work for HIV/AIDS, what worked and didn't work for marriage equality, what worked and didn't work for domestic violence. And when you look at those social change movements, they took decades.
Well,
And
I want to
so,
ask you,
I have, when it comes to stigma reduction, let's go back a little bit. When we talk about if President Trump issued a presidential order tomorrow and said starting 6 months from now, for any state that hasn't required its prescribers to follow certain practices, I'm not going to give you any money for the opiate epidemic. Presidential order, state of emergency. Then prescribing practices could theoretically change very quickly. Stigma reduction, when you look at the time it took to educate the public about this disease, when it talked about HIV/AIDS and those others that I mentioned, took decades.
the reason I ask, and of course, we haven't got a presidential order doing that, have we?
We have not.
And I don't.
And I'm not sure if he has the capability, but Congress certainly could.
Well, I don't want to get into presidential orders
Sure.
and the authority. That's probably too hot a topic
Sure.
for our conversation.
But my
today.
point is, there's certain things could happen quicker than others. And when you
But-
talk about public education, that whole area that's listed in the abatement plan, which one of the components is stigma, but there's other components, it takes time. It takes decades. Well, history has shown factually the time period it took to change our country's view on HIV/AIDS, marriage equality, domestic violence. It took decades.
Okay, I don't want to get into marriage equality and HIV/AIDS. I want to talk about stigma reduction.
Yes.
And I want to ask you if you have said in the past that can be done in a couple of years.
If I've said it could be done in a couple of years, it was prior to 6 months ago when I've been reading all this research, or prior to months ago as I've been reading all this research and seeing the time period it took. And I don't believe now that that can be done in a couple of years. And research proves out what I'm saying.
Do you remember being on a panel with the Washington Post May 4th of 2016?
I remember being on a panel at the Washington Post. I don't remember the date.
And is that on one of the occasions that you said stigma reduction would take less than 2 years?
I don't remember. I just don't recall.
Janice, can we please play Mr. Mendel's comments there? It takes about 2.5 minutes, Judge.
I agree with Ann mostly, like 99%, which is this took us a long time to get into it, and I'll just change one word when you said it will take us a long time to get out. I'll say could take us a long time. You know, my career's been in business, and this is not as complicated as I think it needs to be. A lot of the research has already been done, and all the policy papers say the exact same things. So these aren't my ideas. But from a businessman coming in, my perspective is this doesn't need to be as complicated as it is to resolve it. There's 5 big things in my view that can solve this thing. 4 of them extremely quickly, and 1 that will take time. Extremely quickly, we talked about it. Prescription drug monitoring programs, fully utilized in every state, information shared between states, and information shared with authorized users who can use that information the right way, including health insurance companies. 2, full utilization of the CDC guidelines. That doesn't need to take decades. There could be an uprising in this country. We thought 30,000 people would die from the Zika. There would be people working around the clock to put things in place, like there were with Ebola. Around the clock, headlines every day. Why does the CDC guidelines need to take a decade to get implemented across this country? Why can't they be implemented in weeks or months? Where there's an uprising as if every doctor needs to study the guidelines, change all the protocols that Ann mentioned in the systems, and just implement it right away. It doesn't need to take decades. It can be done in months. The third thing is medication-assisted treatment. More than half the treatment programs in this country still work on abstinence only versus medication, which has proven better outcomes for those addicted to opiates. That state licensing, this could be done in a matter of months, where if you're licensed to operate a facility, you need to offer, there's nothing wrong with abstinence if the patient chooses it, but you need to offer medication-assisted treatment. The doctors need to be trained on it. And the last thing is naloxone. It should be like defibrillators. It should be everywhere. Those 4 things. Naloxone is a medication that will immediately reverse an overdose like a defibrillator is for heart disease. And no one is standing over someone who's struggling, who's not breathing because they just had a heart attack, you're administered with a defibrillator, that bad person, don't waste our time. No, defibrillators are everywhere and administered and save lives. That you just spray up the nose and the person starts breathing again. So that's naloxone. And those 4 things can be implemented by the end of this year, completely. And the last one that will take time is changing the perception that this is a chronic brain disease. That's not going to be done in days or weeks. That could take, not decades, but a year or 2. Not complicated.
You remember that, don't you?
I certainly do now, yes.
Okay. And one of the things you mentioned in that interview was medicated-assisted treatment?
Yes, but let me go back to the comment you were asking about for a second.
And I will. I want you.
Your Honor, I object. Under the rule of completion, he should be allowed to explain the video he just showed.
I'm going to ask him to do that, Reggie. I'm not going to leave that hanging. I had a question in between.
He ought to do it right now, because we just saw it.
I'll allow Mr. Ottaway to ask the question.
Thank you, and I'm going to go right to the video.
I can't wait, Larry.
All right. One of the things, Mr. Mendel, that you discussed in that presentation that you made there was medicated-assisted treatment, MAT.
Yes.
And you know, you were advocating for licensing changes so that each treatment program would offer MAT, correct?
Yes.
Do you know whether the state of Oklahoma has adopted that recommendation?
I don't know of any state that has adopted that.
So the answer is no?
I'm not aware of it, no.
All right. Now, I think Mr. Whitten just can't wait for me to ask you to go ahead and comment on the video.
Yeah,
So please
it's a simple response. I mentioned earlier in my testimony here today that we drafted, developed, and are implementing a 5-point plan to disrupt and improve the treatment system in the United States for addiction. The first step, national principles of care. Done. Next step, quality metric system in this country. Funded, 5-state pilot's been funded, it's being developed, and we're moving through that. Payment reform, provider education, and the last one is stigma reduction. We are now, when I was speaking on that panel, I had not done the research yet on stigma reduction. And I was incorrectly assuming it could be done in a year or two to change behavior, the way people think. I now know from reading 90 articles in published medical journals of what has worked with other social stigmas in this country. And I now know, and this is not my opinion, this is fact. I can send you a list of these 90 articles. This is a fact. The length of time it takes to change knowledge, which change attitudes, which change behavior, which then changes behavior, it's sequential. It's impossible to have that happen in a couple of years. And whether we can beat decades and do it a little bit quicker, because we're going to have a much more, hopefully, not hopefully, we will have a more informed plan completed in the next several months and engage stakeholders all over the country in a coordinated fashion. It's my strong suspicion that we're going to do it quicker than other stigmas have been changed in this country, but there is no research. Every piece of research that I've read and studied, which is all the research that exists in this country, is it will not happen in 2 years. Not even close. That's not my opinion, that's fact.
And in 20 years, Mr. Mendel, is it your testimony that based on the scientific literature in this country, people's attitudes about marriage equality will have completely changed?
Well, there's two qualifications to that. There's two qualifications in the word, is further definition of that question. To change behavior, it's a 3-step process. It's knowledge, changes attitudes, change in knowledge, changes attitudes, change in attitudes, changes behavior. So that's one point. Second point, when you said completely eliminate the stigma of marriage equality.
I said completely change the attitudes about marriage equality.
Okay, fine, sure. There's no completely when it comes to changing the way the country or changing the way people, changing attitudes. There's no completeness. You don't get to an end result of 0. But I can also make sure that the court understands that there are several types of stigma when we talk about stigma, which I think is really relevant and important to understand. There's social stigma, what the public feels. So every data point that someone addicted feels, whether it's as a neighbor, friend, a coworker, not wanting your parents' girlfriends to continue that relationship because they think you're addicted, even though you're not they think, because they know you're addicted but you've been in recovery doing well for 3 years, but because of their view, that public social stigma, all the research shows that's going to take many, many years. Then we talk about self-stigma, which is a result of the public stigma. How does the person who's addicted feel? That caused my son to take his life. That this is not about my son. Let me make that very clear. My son has passed. This is not about my son anymore. This is about everybody's son and daughter in the state of Oklahoma and across this country. And everyone's grandson and great-grandchildren and great-great-grandchildren that are coming in future years. That's what this is about. And this needs to be changed. And let me mention the bigger category. Not the bigger. Equally important is the other two. Structural or systemic stigma within our systems, within our healthcare system, where primary care doctors in the country have said, I don't want to treat people who are addicted to opioids. Let them die off. I don't want to treat people with opioids. Because if I have one in my waiting room, I'm going to have a bunch. It's going to kill my practice. I don't want to treat people with opioids. They just need to stop using. It's their fault. These are not my opinions. These are surveys. These are facts. That takes time. That's the healthcare system, the criminal justice system, where people are thrown into jail, or the criminal justice system that's happening all over the country, where you're addicted to opioids and you're put into jail, and the person in the next cell has diabetes, and they're getting their insulin every day. But you're addicted to opioids, and you're left in your cell to rot with no medication, no treatment. It's happening all over the country today. Why? Stigma. The healthcare system doesn't view this as a healthcare issue. Otherwise, you would get your medication like the person in the next cell is getting diabetes. That's a change in the way we think. And that needs to change, and that is not going to happen overnight.
And do you have anything else you need to offer on that? Because I think most of that came out in your direct,
Out of my what?
out of your direct examination.
I'm fine right now.
Okay, great. And as I understand it, you're here talking about solutions. You're here not talking about blame, correct?
Correct.
All right, thank you. I have nothing more. Thank you for
Sure.
coming, Mr. Mendel.
My pleasure.
May I follow up, Ron?
Yes, you may.
Couple of questions. You remember when my friend Mr. Ottaway was asking you about your deposition, and he was trying to impeach you about testimony about your son's prescriptions? Do you remember that?
Yes, I do.
Your Honor, can I approach
Yes, you
with
may.
the deposition? I'm gonna, if you don't mind, looking over my shoulder. So I'm showing you page 146 of your deposition that Mr. Ottaway was talking about. Did you testify when they took your deposition that your son had been treated for opioid use disorder?
I did.
Did you
I did.
Did you testify on the very next page, 147, that it was my understanding he had taken Vicodin?
I did.
That's an opioid, right?
Yes.
And did you testify, quote, this is on line 5, he had been prescribed Vicodin, prescribed by a doctor for wisdom teeth?
I did.
Am I reading that right?
You were reading it correct.
And did you testify down a little further that he had been involved with OxyContin and Vicodin, right? And then later he moved to heroin,
Yes.
right? And did you testify on the very next page that you remembered that there were some records that you found later in a bag? And are those the prescriptions you told Mr. Ottaway about today?
Yes.
Did you change your testimony?
No.
It's all right there. You just got to read it, right?
Yes.
Now, I think Mr. Ottaway told the court this morning when he objected to your testimony that you had reviewed the abatement plan at your deposition for about, I think Larry said 45 minutes. Do you remember that?
That's what I was told this morning, correct?
Your Honor, can I approach again, Your Honor?
Yes, you may.
Page 119, back when they took your deposition, did you tell him that you had reviewed the abatement plan for probably an hour and a half?
Yes.
Was that enough time to review the abatement plan?
Absolutely. And I reviewed it again for an hour and a half in the last several days. And thinking about that, reading through that abatement plan, what really impressed me was the completeness of it. It's interesting, I'm here in Oklahoma. I met Commissioner White well before I was involved in this trial, who obviously is here in Oklahoma. I was at a conference several years ago, well before, again, any involvement in this trial, where I heard Commissioner White speak really completely and eloquently, the best I'd ever heard, actually, ever, about someone's understanding of primary prevention. If we go back and look at, and I'm happy to supply it, my original business plan drafted back in 2012. It's very detailed about primary prevention, of what we can be doing to raise our children in a fashion that, in a way that has proven without any doubt through randomly controlled trials to reduce the number of our children who ever use drugs and ever become addicted. There's programs that are fit into a family of programs called resistance programs. It's not about drug education. One of the most renowned programs in this country, renowned isn't probably the right adjective, one of the most well-known among the researchers that has really good results is building blocks for kindergarten. Excuse me, not kindergarten, elementary school students. And then as they move into middle school, life skills. These two programs are taught within the school system. And the results are not about drug use. They're about building resistance within our children as they grow up. And the results in the testing is lower drug use, lower criminal justice issues, higher grades, higher graduation grades, less issues with anxiety and depression because they know how to deal with things. That's the results of these programs. And when I read, and the only reason I'm bringing it up now is because there's this notable coming together of a couple data points. One, my reading the first time and then rereading again this plan, the abatement plan, and seeing its completeness. And then thinking back when I first heard Terry White speak and her understanding of that and seeing that in the abatement plan. It's not about drug education, which has proven not to work, frankly, research shows. But these programs have proven to work. I hired, it's just too much to stop me any time, but when I was building that business plan, I hired Steve Levitt, the economics expert that wrote, what's the book he wrote? Can't remember the name of the book that he wrote, but he's
Freakonomics?
Freakonomics. And I searched him out, and he had a team at the University of Chicago, and I retained them back in 2012 when I was drafting this business plan to go through the 45 evidence-based programs that were sitting on the government's website and tell me which ones were most scalable, which ones that had the highest impact that was proven in the research. And he listed all these programs. His report showed all these healthy resistance programs that were identified and spoken really so eloquently and fully, comprehensively by Commissioner White. So I was really pleased to see that in the plan.
Well, let me ask you one last topic before.
But there's many things. I don't want to just highlight that one, but I just want to end with, if I'm being cut off for time reasons, which is fine.
No,
I'm happy to. No, I'm happy to. But I just want to I was just mentioning that one as an example. There are many examples as I looked through that list and saw the completeness of it. But I did see the lack of completeness when it talked about changing stigma. In a paragraph listed with 6 other things with a relatively small budget popped out to me as an omission, which I also mentioned earlier this morning. That was also an omission with the National Academy of Medicine was my recommendation.
Well, Mr. Mendel, the last topic I want to ask you about, Larry brought up the prescription monitoring program here in Oklahoma. Did you know that Oklahoma, the P&P system is mandatory for doctors and requires all first-time prescriptions to be checked? That's a good practice, isn't it?
Tell me what it's requiring again?
Yeah, it's mandatory for all doctors and it's required for all first-time prescriptions.
If that's what it is, that is the best practice.
Then the second thing I'm going to ask you about, Mr. Ottaway brought up the P&P relative to the benzodiazepine questions. Do you remember those?
Yes.
Did you know that Oklahoma has an alert in the PDMP whenever a benzo and an opioid are prescribed, that alert is issued? That's a good thing too, isn't it?
It's more than a good thing. It is phenomenal. That's fantastic.
And Oklahoma's been a pioneer in the PMP. Oklahoma's not been one of the states you've had to pester on the PMP system like some of the other states you've been trying to move forward.
I can't say that. What I do know is the first state to recognize its value beyond diversion into helping to reverse the course of the opioid epidemic was Kentucky. The second, which is 2012. New York was 2013. Tennessee and Ohio were 2014. And then we jumped in and we got legislation passed in many states that we drafted and pushed through. And at the time, when we switched our priorities 2 years ago to other policies, Oklahoma at that point was not one of the states required. Now, if they passed it in the last couple of years, or if there's some qualifications to it, which doesn't meet our test, and it may, so I just don't know.
Your Honor, may I approach?
Yes.
I want to show you on my iPad, this is the clinical alert part of Oklahoma's PDMP. Take a look at that. That's the clinical alert that I asked you about.
Sorry, I got it.
My question's going to be, is that a good thing?
The first two are great. The third one is above the guidelines recommended by the CDC. CDC would probably want that alert at either 50 milligrams or 90, not 100.
Okay. All right. Thank you, Mr. Mendel. That's all I have.
Mr. Mendel, you may be excused.
Excuse me, I just have two questions on that.
Okay, we'll give you that opportunity.
You were talking about the PDMP there, and I want to make sure Judge Bachman understands. Best practice is to check the PDMP for all prescriptions, correct?
No, the CDC recommends before considering prescribing an opioid. It's recommendation number 9 of the CDC's 12 recommendations.
I meant all opioid prescriptions.
No, the CDC recommendation is within every, when you prescribe, you only prescribe it for 90 days, and so you check it within every 90 days.
3
Not
months.
Every 3 months.
And so if Oklahoma has 6 months, that's not best practice, correct?
That's correct.
And one last thing, Mr. Mendel, if we can come and approach.
Yes, you may.
Here's where I got the 45 minutes. Let me just ask if this question was asked. Council, page 23, starting at line 9. Is there any work that you are doing on this case that was not complete at the time that you issued this disclosure? Can you just read for the court your answer?
Sure. I haven't been doing any work on this case. I was called to ask if I would be willing to testify. I said yes. This was prepared, and I read it and improved it. I met with some attorneys for an hour and a half on Sunday. I reviewed Exhibit S this morning for 45 minutes, half an hour, and I am here.
Thank you, sir. Was that question asked and that answer given by you?
Yeah, it looks like I was inconsistent. Looks like on one place I was saying half an hour to 45 minutes, and another place I answered an hour and a half. So I was inconsistent.
Nobody's perfect.
Okay.
Thank you. That's all I have, Your Honor.
May I follow up?
Yes, you may.
You know why Mr. Ottaway is quoting on page 23, when I showed later in the deposition, you corrected it and said an hour and a half? Why would he show the earlier one when you clearly corrected it on page 119 and said an hour and a half?
I can't speak to his motives.
Do you know why Johnson & Johnson is lecturing the state of Oklahoma on how they should make their PMP law better?
Excuse me, object to the form of the question.
Sustained.
That's all I have. May he be excused, Your Honor.
Yes, you may be excused.
Thank you for coming, Mr. Mendel.
Thank you. Thank you.
It's nice to meet you.
We will invite the state to call its next witness.
Thank you, Your Honor. Drew Pay for the state. This time we call the Chief Medical Examiner, Dr. Eric Pfeiffer.
Okay. And Mr. Pate, we'll plan on stopping shortly after noon.
Shortly after
12
what
noon.
time?
Right around 12 noon or thereafter.
Understood. Thank you, Judge.
Okay. Dr. Pfeiffer, please raise your right hand. Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth?
Yes.
Thank you.
Good morning, Dr. Pfeiffer.
Morning.
Can you please introduce yourself to the court?
My name is Eric Pfeiffer, E-R-I-C-P-F-E-I-F-E-R.
Where do you live, Dr. Pfeiffer?
Live in Edmond, Oklahoma.
And what is your job title
I'm the Chief Medical Examiner for the state of Oklahoma.
for the entire state of Oklahoma?
Yes.
How long have you had that role?
About 8 years and a month now.
And if you can, briefly, just describe at a high level what your responsibilities are as the state's chief medical examiner.
I wear two hats. I'm the executive head of the agency. The agency exists because of a state statute to investigate certain sorts of deaths and report on the cause and manner of death. And I'm also a practicing forensic pathologist, so I actively am involved in the autopsy practice.
Prior to becoming, we'll get into a little bit more of the details of what a forensic pathologist does and what you do in that role. But prior to becoming the chief medical examiner for Oklahoma, what did you do?
I was a diagnostic surgical pathologist and a forensic pathologist at the Mayo Clinic in Rochester, Minnesota from 1997 until 2011.
All right. And what did you do there?
Again, practiced both diagnostic surgical pathology, and I was initially the coroner of Olmsted County, which is the county in which the clinic is located. And later, after the statute changed, I became the medical examiner of that county.
So that job involved a lot of the, or at least part of the same responsibilities that you have now as a forensic pathologist in the state of Oklahoma?
Yes.
Can you walk us through your educational background?
Yes.
Starting with your bachelor's.
Bachelor's degree in chemistry from Emory University, graduated in 1988. Took off some time during some summers and actually a full year during my college tenure. I studied physical chemistry at the Ruhr University of Germany in Bochum, Germany, and did some work in electrophysiology at Oxford University in England during that time. After college, I went to medical school, which was at the Medical College of Georgia in Augusta, Georgia, right next to the golf course. And from 1988 until 1993, went to medical school, graduated in March of 1993, entered internship and residency in anatomic and clinical pathology at the same institution. In 1996, I went to Rochester, Minnesota to do a fellowship in anatomic pathology that included training in forensic pathology. Stayed on the staff there for 14 years until I came here in 2011.
Now you mentioned the golf course. I know we're all wondering whether you actually got to play at Augusta.
Never.
It's too bad.
Thank you for asking that. I'm disappointed with the answer.
We all are. I'm sure he is too. Now, do you have any board certifications, Dr. Pfeiffer?
Yes.
What board certifications do you have?
Anatomic pathology, clinical pathology, and forensic pathology.
Okay. Can you just maybe slow down a little bit and walk through each one of those and kind of explain what those board certifications allow you to do?
Sure. So anatomic pathology is the study of the pathologic basis of disease. Why do diseases happen on a cellular or tissue level, and how to recognize those diseases with both the naked eye but also the use of a microscope. And so that training and certification would allow me to practice surgical pathology anywhere in this country. And that is indeed what I did for 14 years in Minnesota in conjunction with the forensic pathology. The clinical pathology part would permit me to oversee work in a laboratory such as a microbiology laboratory, blood banking, or a clinical chemistry or toxicology laboratory. And the forensic pathology is a very subspecialized field within the practice of pathology that concerns itself with the determination of cause and manner of death in persons, documentation and preservation of evidence, and reporting those findings.
All of those things you mentioned are part of being a forensic pathologist?
Yes.
Now, you use the term surgical pathology a
Yes.
couple of times. What is a surgical pathologist?
That would be a physician who, in a practical sense, receives a tissue biopsy or a piece of tissue or an excised organ and then diagnoses the specific disease that that organ has or that that patient has.
Now, you've been, I think you said, in your role as the chief medical examiner for the state of Oklahoma since 2011. Is that right?
That's correct.
All right. And in that role, are part of your responsibilities also to testify at trial?
Yes.
Okay. Are you regularly called upon to testify as a witness in trials?
Yes, very often.
Okay. What are you typically testifying about?
I'm typically involved, in fact, the vast majority of cases that I testify in are criminal trials.
And if you can, at a high level, describe kind of what you're typically asked to testify about. Are you called to testify as an expert witness usually?
Yes. And to describe cause and manner of death, injuries, any questions of that particular patient that might be of interest to the law, and to explain documentation and preservation of evidence.
Now, can you just explain for us briefly what the office of the chief medical examiner, not just you in your role, but your entire office and department do at a high level?
The office was started in the late 60s in Oklahoma. It was recognized as a need of the state when a woman by the name of Nanny Doss poisoned her last husband, I believe, in Tulsa. And so the state recognized a need to have an organized way of investigating these deaths that previously hadn't existed. So a statute was enacted, Oklahoma Statute 63, and the office was created as a result of that. It wasn't funded until two years later after that, but it is charged under law with investigating certain sorts of deaths, unexplained deaths, deaths due to violent means, deaths due to drugs or poisons, unattended deaths, deaths of persons involved in fires, deaths of children that are unexplained, and a few others.
Can you spell the lady's name that you mentioned?
Nanny Doss, Nanniedoss.
And so you mentioned part of your responsibility is to investigate those types of deaths. What then are you supposed to do after the investigation, or what is your office charged with doing?
I guess ultimately what we do is issue a report of those findings that can be used by other agencies.
And what kind of cases does the chief medical examiner's office handle? What kind of death cases?
We see a lot of them. So in the unattended category, we see a lot of natural deaths. Might be from heart disease or cancer, but because that patient was unattended, there's a little bit of mystery of what might have happened, even if there is a documented clinical disease. Certainly things that are of violent means, so gunshot wounds, motor vehicle accidents, stabbings, deaths due to drugs and toxins comprise a large number of the cases that we look at as well.
Does your office investigate every single death that occurs in the state of Oklahoma?
No.
With respect to the cases that you do investigate, you investigate drug overdoses?
Yes.
Do you investigate every drug overdose that happens in the state of Oklahoma?
I would say probably not, because it's a function of whether that death is reported to us. So I think particularly in the elderly population, in which most of these patients have some sort of disease that could be considered fatal, that I suspect some of these are not reported to us.
Do the drug overdose deaths that your office investigates include overdoses from prescription opioids?
Yes.
And similarly then, with what you just mentioned, the example you gave in the elder population, do you believe that there are people who have died from prescription opioids who likely were never reported to your office and that you never investigated?
Almost certainly.
And so the numbers that, back up, your office issues reports based on your findings of the investigations that you do, correct?
Yes.
And you report that information to other state agencies?
Yes.
And the numbers that we see then that are reported from the medical examiner's office related to prescription opioid deaths could be underreported. Is that fair?
Yes.
Now, how is I assume you're not the only forensic pathologist at the medical examiner's office.
That's right.
How is your office made up, staff?
We currently have 103 staff. 10 of those are forensic pathologists. We have an admin staff. We have toxicology staff consisting of 2 forensic toxicologists, 6 analytical chemists, and a QC chemist, QC/QA chemist. That's quality assurance, quality control chemist. We have investigators that are, in the case of Oklahoma City, all board certified to investigate deaths and report those findings back to the forensic pathologist to begin the investigation.
All right, so let's walk through, you mentioned 3 groups of people that I kind of want to talk about. So you mentioned investigators, right?
Yes,
Forensic pathologists are part of your team,
yes,
and you have members of a toxicology team, is that right?
that's right.
All right, let's start with the investigators. Can you give us an overview of what your investigators' responsibilities are?
They are the initial eyes and ears of the organization. So when a phone call does come into the agency to report a death, these are the people that get involved first, collect information. It's recorded down in our database, and they may or may not get in their vehicle and go to the scene of that death to collect more information. And it's analogous to a clinician asking a living patient, hey, what's wrong with you? Where's the pain? How long has it happened? Although our patients are deceased, this is the beginning process where we get that information to start the investigation.
So you still refer to them as patients when they come into your offices?
I do, yes.
And you view it as a doctor-patient type relationship where you're trying to diagnose why that person died, is that right?
Yes.
Now, going back to the investigators, what sort of qualifications and training do these individuals have to have who are going to the scenes where these deaths occur?
They all have to have a college degree, preferably in a scientific field, and then they have to achieve 640 hours of training on the job. They have a certain set of criteria that need to be met, certain skills and abilities that they have to achieve, and those are all internal things that we set, standards that we set for them, and then they sit for a board examination for the American Board of Medical Legal Death Investigation, and that's required within 2 years of employment.
And how many investigators do you have right now?
30.
Do they all meet these qualifications?
Yes, the ones in Oklahoma City do. We have some younger folks in Tulsa that are still in training and not eligible to sit yet.
Are those the 2 offices, Oklahoma City and Tulsa?
Yes.
All right. Now, you also mentioned, and I believe you're a member of this group also, the forensic pathologists?
Yes.
Okay. Can you explain to Judge Balkner what the responsibilities of a forensic pathologist are?
A forensic pathologist has to be a medical doctor, whether an MD or a DO. They have to have subspecialty training in forensic pathology, and they have to pass a board examination in forensic pathology to be employed at our agency. Their responsibility is really the mind that coordinates all the little facets of a case that come together to make a diagnosis of cause and manner of death.
And what sort of qualifications and training do they have to have?
They have to be medical doctors, whether a doctor of osteopathy or an MD. They have to have subspecialized training in forensic pathology and to pass a board examination by the American Board of Pathology in forensic pathology.
And these are the doctors like yourself who are making an ultimate determination on the cause of death of the individuals that you investigate. Is that
That's
right?
correct.
And how many forensic pathologists do you have?
Presently 10. 2 more are joining us in July and August, respectively. And we have a fellow in training that we are sort of home-growing our own forensic pathologists here.
And is that across both the Oklahoma City and the Tulsa office?
Yes.
All right, now what about the toxicology team? You mentioned a few different kinds of chemists, I think, that I didn't catch all the initials. Can you explain who makes up the toxicology team?
Sure. There are 3 principal divisions. At the top of the hierarchy there would be the forensic toxicologists. They have to be PhD forensic toxicologists who are board certified by the American Board of Forensic Toxicology. They are the ones that are responsible for looking at what the forensic chemists produce with the instrumentation to make sure that those results are valid and accurate, and to help the forensic pathologists with interpretation of the presence of drugs and the various drug levels in the determination of cause and manner of death. We have a special chemist there called a QA/QC chemist. her role is almost primarily to make sure that the instruments are running accurately and precise. And she does that by running calibration tests with a high purity standard, but also engaging in the College of American Pathologists proficiency testing program, in which an unknown sample is sent to us occasionally with no clue of what's in there, and the lab has to correctly identify the chemical and the concentration of that chemical in that sample to meet ABFT, or American Board of Forensic Toxicology accreditation standards.
That's your QA/QC chemist?
Yes.
Is that a hard job?
I would imagine so. A lot of that's way over my head.
Right. All right. Now, how many different people make up the toxicology team at the office, at your office?
Excluding the admin staff, and I'm not trying to diss them at all, but the people that actually do the analytical work would be 6 chemists. Occasionally, the 2 toxicologists, PhD toxicologists, get involved with that, and then the QA/QC chemists. So that would be 6, 7, 8, 9.
And you have 2 forensic toxicologists, is that right?
Yes.
And who are they?
Dr. Byron Curtis and Dr. Jesse Camp.
Between the 2 of them, how much experience do they have as forensic toxicologists?
Over 40 years.
Now, when a drug overdose case gets reported, how does that process start? Who first notifies your office?
That could be a number of different people. That could be a law enforcement officer who attends the scene and finds a dead body and gives us a call. It could be someone at a hospital. It could be a hospice nurse. It could be a family member that gives us an initial phone call, and then we would send an investigator out to that scene.
And what does the investigator then do?
They collect the initial information, much like the history, the patient history of a living patient, who that patient is, so the identity, where that patient died, what position they are when they're found, what are the circumstances of death, are there objects on the body or around the body, or is there an appearance of the body that might suggest an apparent cause of death.
And all of these things are done for any investigation that your office conducts, is that right?
Most of them, yes.
Including a drug overdose investigation?
Yes.
Okay. You look at, and these investigators, when they're there, are they writing down all of these observations that they're making?
Yes.
And where do they do that?
They are all issued a notebook or a laptop, and that a narrative that they create is fed into our database. And that's a database of information that's kept indefinitely on a server at the state.
And all of that information, who the patient is, the circumstances in which they died, is that all information that you or one of your other pathologists will eventually use to make your diagnosis of the cause of death?
Yes, it's a starting point. Things and other information may come to light that changes the initial trajectory of that investigation, but that's the starting point of all our investigations.
So after the scene investigation, what happens next for your office?
Body would be transported to one of the 2 offices, and an examination would occur. That examination could either be an external examination of the body to look for signs of disease, or an external plus an internal examination. The internal examination is what we would traditionally call the autopsy. It's a surgical opening of the body to look at the organs for signs of disease or injury.
At what point is the toxicology team brought in?
During the internal examination of the body, various samples might be taken, such as blood from a vein or an artery or from the heart. There's fluid in the eye that it's very useful forensically as well, or organ tissues for additional analysis if we need to. Those samples are collected at the time of autopsy. They're put into a carrier, put into a dumbwaiter, and then they go up to toxicology, which is on the floor above us, above the autopsy suite. When the toxicology lab receives that, they will also receive a sheet of paper that requests, or at least gives them an idea of what we're looking for. And then they begin the process of screening those samples for the presence of drugs. And if something is found of significance, they will go to further confirmatory testing with more sophisticated instrumentation.
Can you walk us through the the different tests, the different phases of toxicology tests that your office would then conduct?
Yeah, I'm probably not as exhaustive as the toxicologist, but there are 3 or 4 major testing modalities. We use principally as our screening tests, so this front line to identify what drugs are there. We would use something called an EIA, or an enzyme immunoassay. We have 2 of those machines running around the clock. They can give you a semi-quantitative assessment, so they can tell you whether or not there's a lot or a little bit of drug there, but they're not really great at accurate levels. But they tell us what's there. Now, there's some limitations with that testing, and so if we suspect something like clonazepam, which the EIA wouldn't pick up, we'd note that, and it would go to different sort of testing right off the bat. From that point, it could go to one of 3 instrument rooms. We have 2 machines set up to analyze volatiles, so that would be alcohol, acetone, the 1,1-difluoroethane, and the paint huffers, or the office duster huffers, acetone, xylene, that kind of thing. We have an instrument room called the GC room, which are gas chromatograph. Then we have 9 of those robots running around the clock to both qualitatively and quantitatively tell us what's there in various samples. And then we have a very sensitive types of instrumentation called liquid chromatography, mass spectrometry. We have 2 of those instruments in addition to a new instrument that we just got last year called an accurate mass or time of flight instrument that can detect picogram amounts of drugs very accurately.
Tanya, we may have to get you a new dictionary for some of these terms. We'll work on that on break. Dr. Pfeiffer, did I hear you say, though, that 2 of those tests that you run somewhere in the middle that I can't pronounce, that they're trying to test for the amount of the substance after you detect what substances are present? You then run a test to see what amount of the substance is present in that person. Is that right?
Yes.
All right. Why do you do that?
In forensic pathology, it's oftentimes important to know what the drug is. So there are some drugs that are not safe at any level, like methamphetamine, but other drugs have concentrations that are potentially make them poisonous or lethal.
Such as opioids?
Yes.
Okay. And so when you're testing for, when the tests come back to determine that there are opioids in an individual, you run a further test to determine what amount. Is that right?
Yes, not only what amount, but what exactly that metabolite or drug is.
And why is that important for you to do that for opioids?
Well, opioids can kill people, and there are different types that have different toxic ranges and different potencies. And so some drugs are more lethal at lower doses than others. So it is important for us to know exactly what that drug is and its concentration.
And certain people can have different tolerance levels for opioids, can't they?
Absolutely, yes.
And is that something that you factor into your analysis as well?
When we can, yes. We try to look at what the tolerance is, and we gather that by a variety of different means. In the last few years, we have had direct access to Oklahoma's PMP. So we can look at the drug prescribing history, although sometimes it doesn't tell us exactly what that patient might be ingesting if that's not included on the PMP. But yes, we do try to make an assessment of tolerance when we can.
For a particular patient who's already in your office?
Yes.
Your Honor, if you'd like to take a break now.
Yeah, we will go ahead and break for lunch. I'll excuse the parties, and we'll return and begin again at 1:30 this afternoon.